Good morning, and I'm Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, in for Dr. Stites this morning, and we are coming to you live from the Dolph Simons Jr. Family Broadcast Studio. In June is National Migraine and Headache Awareness Month, and so we have neurologist and migraine specialist Dr. Deetra Ford joining us today in studio to talk about COVID's impact on migraines and how to know if you're suffering a migraine or a COVID-19 headache. But first of all, I wanted to share some of our inpatient numbers. Last night, we do get inpatient numbers twice a day here at the health system. Last night we had 13 active inpatients. This morning we have actually 17 active inpatients, with 2 of those in the ICU and one on a ventilator. We still have 8 in that additional recovery period as well. So our numbers are creeping up. And I just would like to let everybody know, too, I talked with a colleague yesterday from a hospital around the region. He saw in consultation 4 new patients in the ICU. All were under the age of 40. And all had severe COVID disease and other new issues going on as well. They were all unvaccinated. So I know that there was some news reports yesterday also about one of the people in the government talking about the new Delta variant is like COVID on steroids. So we know that these variants are prevalent now, is particularly the Alpha, which is the UK variant, and the Delta variant, which was the India variant. We know those are becoming more dominant, especially the Delta variant. So it is vitally important for everybody to get vaccinated. If you know people who aren't vaccinated, please encourage them to get vaccinated, because we do believe their risks are going up for one reason or another for severe disease and hospitalization and death. There was a study also yesterday that was mentioned by Isaac, I believe, who asked about a common cold and can that protect from COVID-19. I didn't really have a lot of information. I had surmised maybe it had to do with the interferon. After going through that article and that study, that's exactly what it is. We know, and we are learning more and more, how coronavirus or COVID-19 is able to actually reduce or tampen down your initial innate immune response, and one of those things is interferon, which is just a chemical your body secretes against foreign invaders, particularly viruses. We know that COVID-19 can interfere with that, and what this study shows is if you get infected, say with a rhinovirus, a common cold, 3 days before, you can have an increase in your interferon levels. Again, this was a study that was done in the laboratory. It was done in culture cells. I think you have to apply that to either animal models or the human model, but it is good information, and it is consistent with what we are seeing. Coronavirus is able to antagonize or act against our normal innate human defenses. So, but that's just one more piece. But that does not mean everybody should be running out getting infected with cold viruses. Again, it's just one more piece of the information we're learning about the pathophysiology of COVID-19. So, before we go to our guest, are there any reporter questions?
I do have one from Cody over at Channel 9. He's anchoring this morning, so he asked me to read his question, and it's from a viewer. And the viewer writes, Royal Caribbean had to postpone a cruise because some of his crew members tested positive for the coronavirus. Yeah. They tested positive before the end of a 2-week post-vaccination period. So the question is, if people plan to travel, should they wait until after the 2-week period? Why? And what are your thoughts?
Yeah, you know, we do know that you get some partial protection, especially against those early variants. You know, now with particularly the South African or the Indian variant, which was Delta, we are unclear exactly how much immunity you have. You still do have immunity based on some antibodies, but also those T-cell responses as well. We don't consider you fully vaccinated until 2 weeks after that second dose of the mRNA vaccine, or 2 weeks after Johnson & Johnson. Should you postpone? I think, you know, other things you can do that we had talked about previously is maybe continuing to do those things, those non-pharmaceutical interventions like masking and distancing, maybe really reducing your exposure prior to travel. That could be something to do to help reduce your risk of testing positive before you go, because I know that can be a terrible time if you are supposed to go somewhere and say, test for COVID, 72 hours prior to travel. If you are positive, that could seriously impact. The other thing to do is also consider getting travel insurance. But those are things that you can do 10 days or 14 days before, even if vaccinated, is to continue to maintain distance and do masking. And if you are going places and doing things, make sure you're doing those things outside.
Nothing is worse than getting sick when you travel.
I know.
So I think that's all that we have.
All right.
We're ready to talk headache.
Yeah. Right. So now we'll go to Dr. Ford. So Dr. Ford, how has the pandemic affected your headache patients? We know stress can be a trigger for migraines, and certainly just the thought of COVID out there, not COVID itself, but just the thought of COVID can induce anxiety and stress as well.
Absolutely. So we've actually seen a shift in two separate ways completely. One of those is the people who do have the stress as the trigger and have had more migraines, and then we've actually had the opposite. So a lot of the folks who are now working from home are reducing some of the stressors that they had. They're able to control their environments more. They're able to control for sound, for perfumes, colognes, for lighting. They also are able to take breaks on their own time, hydrate better. So some folks have actually done really well with this pandemic, with more time for working from home. Other folks, though, have had the stress as a big trigger, the anxiety, and again, with that staying home more, we have had more of the depression and anxiety shine through, and those are big triggers for the migraines as well. So it seems to have been a very direct split. So we've been working on a lot of stress techniques, had people referred out to Turning Point and some of our pain psychologists to help with those things as well, and just psychology in general to work with that, because we know that that is a help for some of those patients. But the working from home has been the biggest change, and I think that'll be an interesting challenge as we move back into our more normal environment.
Yeah, and we know, headaches and migraines are extremely common, and just so thankful for you and your team. She's an excellent physician. I have referred many patients there, and it's been good that we have this resource here at the health center, at the health system. So is there a difference between COVID-19 headaches and a migraine?
This is a great question. So I think it's very patient dependent. I have some patients who've had very significant headaches after their COVID-19 infection that lasts for literally weeks to months. And some of them are different than their normal migraines. It's more of a dull pressure headache that is actually still pretty significant in intensity and severity for them, but it just doesn't go away. There's nothing that really works to treat them as well as a specific migraine. So the regular migraine medications don't seem to work as well. We have had a little luck with some things that we don't typically use as often, like gabapentin and Depakote for short term, but not something we'd recommend long term in a lot of folks. But we've had to change our ideas of what that management looks like for a lot of those patients. The interesting thing for the migraineurs, though, are that the migraines that they do get after having COVID-19 infection are actually sometimes more intense and severe than they were before. And that does tend to get better over time. And one of the things that I like to bring up is the post-vaccine headaches that we've seen as well, because I know that I've had a lot of my migraineurs either email in or ask questions saying, is this vaccine going to make things worse for me? And so there is a chance that you might get some headaches for 3 to 5 days after you've had your vaccine, and they're not going to be typical migraines. Usually, again, it's going to be that duller headache, but what I tell folks is it's much better than having the COVID-19 infection and having the severe headaches that are going to potentially last for weeks to months after. And it's also not a guarantee you're going to get the headache. Much better to have a vaccination, possibly get a headache that we can treat effectively, than to have COVID-19 and end up with headaches for months that we cannot treat effectively.
Yeah, and thank you for addressing that. We know we have so many questions about vaccine and vaccine hesitancy, and again, migraines do affect so many people. Headaches do. I think that was an important topic to address. So thank you very much for that. But also, besides the pandemic, and you alluded to this in your first answer, what are some of the other common triggers for migraines?
Absolutely. So stress in general, obviously, that's one that hits everyone. Sleep patterns. Sleep is huge. So sleep hygiene is something I totally preach in clinic, and we have all kinds of handouts to try to help, because we're all terrible at that. Everyone has, too many irons in the fire, too many things going on, children with practices, school, moving from one place to another, jobs, working from home, which actually, sometimes ends up being longer hours. So really concrete that sleep in is really helpful. So making sure you have a good sleep time and wake time, and then, treating any uncommon sleep apnea type triggers, things like that can be helpful. So that's one of the biggest ones besides stress. Other ones, again, are environmental. So bright lights, fluorescent lights. So we've talked a lot about having blue light filters, and you can get a lot of those things very inexpensively on Amazon or even at Walmart to help with, your work environment if you can control it. Again, computer and screen time is a big one, and obviously most of our jobs now consist of computers and screen time. And so working on, again, the blue light blockers, there are a lot of different lenses that you can use as well with your computers, and changing fonts, those things help. But then more, dietary triggers. I have a lot of folks who will try to come up with a good migraine diary and try to find dietary triggers. I think the most common ones are going to be your alcoholic beverages, particularly wines. Chocolate is a big one. Too much or too little caffeine. I'm not one who says you can't have any, because I think that's unrealistic, but I usually say, holding it to that 300 to 400 milligram, dose per day, and trying to stay consistent with that, no matter whether it's day of the week or the weekend, because we know that's a big one. And there are a whole host of others, but those are big ones. Weather is the other giant one that I want to make sure we mention. And so we do see that there have been lots of studies trying to see if it's a high or a low barometric pressure and trying to put that together. And I don't think we have the answers to that completely, but we always know when there's a storm coming in because our messages are off the charts. So we know it's real. It's just a matter of how to quantify that.
Yeah. And then, so how do you know if a headache that you're experiencing is a migraine headache or something else?
Yeah, so, there are some very clear criteria for migraine, and then things get blurry after that, of course, but typically it's going to be a unilateral, so one-sided headache. It's typically going to be something that's a throbbing or pulsating feeling, and at least moderate severity, so it's not going to be your dull, kind of achy, band-like headache. A lot of people are going to have light and sound sensitivity or nausea or vomiting, so those are kind of some of the criteria that we use. It often will affect your activities of daily living, and I know, some people can function through those and some can't. We all have different pain tolerances, number one, and number two, not every migraine is built the same. So some people may have a migraine one day that is something they can function through and take their normal migraine meds and be fine, and another day it might be severe to the point they're having the vomiting and are unable to function throughout that day or work. And so it's very different in that regard. And then in terms of other headaches, tension headaches are probably the second most common that we're seeing now with the pandemic, with, again, just the stress and computer time that people are having compared to what they did before. So I would say that's another very common one recently. But again, it's difficult to say that someone doesn't have a migraine just because they're working or smiling or doing their own job and their normal functions, because again, everyone experiences this so differently. So I challenge people to not make judgments quickly and really hear out how they're feeling and what their symptoms are.
Yeah, and you talked about functioning. Is there any way to tell or predict in a person or any specific event of a migraine for that particular person who's going to be able to function and who's not?
Yeah, so again, very different. I think it depends a lot on comorbidities as well. So I think a lot of comorbidities with people who do suffer with chronic pain are fibromyalgia patients, folks who've had traumatic brain injuries or brain tumors. They're going to have a lot more difficulty, I think, with functioning with some of those headaches. They have a lot more trouble. The other ones that tend to really throw people for a loop are the ones they wake up with. So it's a lot more challenging to make your migraine medication work when you wake up with a headache or a migraine in the middle of the night or early morning and it's already had a chance to grow and bloom into a full migraine. Our medicines are definitely way better tolerated and better targeted for people who develop a migraine throughout the day.
So what new therapies are available, and how does a person determine what might work for them?
Absolutely. So we've actually, for the first time in a long time, in the last couple of years, had a lot of new therapies become available to us. Some of the newest things on the market are the calcitonin gene-related peptide drugs, and so we won't get into too much science with that.
Yeah.
But
is there an abbreviation for that?
Yeah, so we just say CGRP. So they work as basically kind of a blocker or an antagonist to those, and so we know that having too much CGRP has been proven to be associated with migraines, and so the thought was, can we block that and make those better? So the newer therapies that are out are going to be targeted mostly to that. So there are 3 injectable therapies that are out and 1 infusion that can be done for that, and those are more our long-term prevention meds. And then there there are some what we call G pants. So again, we won't get too far into it, but work on a similar target, but a smaller molecule. Those are prior to just a week and a half ago, those were only for acute therapy. The FDA just gave approval for rimegepant to be an every other day prevention and acute model medication. So that's the first time we've had that. They actually went up for approval back in December and just got it. So we're actually really excited to be able to use that. That's a disintegrating tablet, so it helps with those folks who are really having a lot of nausea or vomiting, and so they're able to tolerate that a little bit better. So we're hoping that commercially will be available actually this week. So we're excited about that one.
Yeah, and are those acting on the blood vessels or the neurons in the brain? What are they?
Great question. So probably a little bit of both, but definitely with blood vessels. So the benefit with these are, with our previous medications like the regular triptans, so people are probably familiar with Imitrex or sumatriptan, Maxalt, those types of medications, they had a side effect of vasoconstriction. So they actually made your blood vessels smaller. And so obviously if you'd had a stroke or a heart attack, that was something we really wanted to avoid, or even if you had a lot of risk factors for that, because obviously we don't want to induce that. These newer medications actually don't cause vasoconstriction. They have a theoretical risk that they don't allow for a lot of vasodilation because they kind of just hold the vessel where it is and block that vasodilatory effect. But overall, considered much safer in patients with potential stroke and heart attack risk factors. Still something we would definitely want to counsel and talk about before we went that route. And there are interactions with a lot of the meds that we use for especially cardiac problems and high blood pressure. And so it's something you definitely want to talk to your doctor about very carefully before you start one of those medications, but that is where the benefit is that they don't have those same risks and work a little differently than the meds we had in the past.
And vasodilation meaning?
Yeah, so the blood vessel getting larger, and so when we talk about stroke and heart attack, we worry about the blood vessels having constriction or being too small. So we worry about cholesterol plaques and things building up in the arteries. And so when you constrict that down further, I kind of give my patients a hose, a normal garden hose tuck. And so when we're going to constrict that down further, you're going to have less flow going through there and it becomes turbulent. And so that's where the triptans we think have a little more risk because they're constricting down those pathways a little bit more. And so these newer drugs don't cause that constriction or narrowing of the blood vessel like they did before. So you still get your hose nice, wide, and open, and blood flow is still going through it. They just don't allow it to dilate more, and that's where we think part of their efficacy comes from.
And do you have a favorite intervention or one of these new ones, or do you have an algorithm that you go through that you start with one and then go to sequentially to others?
That's a great question. So this is something that has been highly debated recently in the headache world. And so, in the past, we had a lot of our regular meds that we used off-label. So we had our anti-epileptics or anti-seizure medicines. We had our anti-high blood pressure medications. We had our antidepressants. And we use those what we call off-label because we knew they had some benefit in headache, but they weren't made for headache. And so the newer drugs are actually labeled just for migraine. And so they've been brought out just for that. So there are some people who feel we should be able to go straight to those medicines. Now, although I think that would be a great plan, insurance doesn't always allow us to do those things. So there's a lot of things that go into those decisions. Currently, kind of one of our favorite things to do, which is again an insurance block sometimes, is for our really chronic migraineurs, we like to do the Botox injections and one of the CGRP medications because we know they have a little bit of a synergistic effect. And we have seen our best relief with that combination. Unfortunately, it has not been formally studied to where we have data that we can present to insurance companies, but slowly but surely we're getting more people available to have both on board. And I will tell you that that's been where our kind of sweet spot has been for our treatment of the chronic migraineurs.
All right. Well, thank you. And with that, any questions, Jill, from the community?
Oh, yes, we do. And we have them, again, it's kind of a mix. We have some pandemic COVID questions and we have some headache questions, which I'll start with the headache questions. And first I want to share a comment. Vicki wants people to know that she's a migraine sufferer, and when she has them, they last 72 hours, and that a migraine is so much more than a headache. She just, my mom is a migraine sufferer, and my sister was. It skipped me, which leads to another question. Are they hereditary?
They can be. So we do ask family history on migraine, and there are some types of migraines, in particular hemiplegic or motor auras, that do have potentially some genetic links as well. And so that's something that with Children's Mercy has been studied recently and will be over the next hopefully 12 to 18 months. So.
Well, I really feel for Vicky and my sister and anybody who suffers these, because I grew up with it. You know, the family suffers when you suffer, for sure. Vicky says that she took Maxalt and she said it knocked it out both times. She got a migraine after she got her shots. So I want to turn her statement into a question. Is that common, that if you are a migraine sufferer, that when you get your vaccine that you are going to get the headache?
So again, it's not a definite, but we have seen that, and I think if you even look at the data, the vaccine data that they collected so far, it's actually been a pretty common side effect. And yes, migraine is definitely possible after, but again, I feel like most people have had this kind of just duller, different headache. It wasn't quite to the migraine intensity, and usually, again, 3 to 5 days has been pretty common, and it's pretty solid that whole time with nothing touching it. But absolutely, migraines are possible during that time, and we do recommend to take your typical migraine cocktail that you've been assigned by your physician.
And I would probably say that, having kids is probably a risk factor for a headache. That's why I can't believe our good friend Dr. Burns with 10 kids doesn't walk around with a headache 24 hours a day.
Yeah, that's a big mystery. Mary says, what's the connection between systematic inflammation and migraines?
Good question. So that's kind of what I referred to earlier a little bit, is that we do see different severities and frequency of migraineurs depending on their underlying comorbidities. And so a lot of our autoimmune patients do tend to have a lot more headaches and migraines. And we also see that again with the COVID and illness in general. And I'm sure Dr. Hawkinson can elaborate on that as well, with just the inflammatory response that our body has. But again, we do see that frequently, and the severity is sometimes worse in those patients. And again, we work to manage it from both aspects of treating the underlying systematic diseases as well as the migraine itself.
And I think if you have a diagnosis and you have that going on, I think that's going to add more stress, which is, again, another risk factor that you would describe. So, yeah.
Right. So Angela writes, Dr. Ford, do you treat, and it looks like she's written IIH patients. What is that?
Yeah, so IIH is idiopathic intracranial hypertension, previously referred to as pseudotumor cerebri. So a lot of people know it by that name. And it's interesting that she brings that up, because we were just talking about that in clinic. We have seen a huge number in the last month, literally, of IIH patients. And it's a little bit atypical for our numbers that we usually see. We've actually had 3 in just the last 10 days. And so I'm not sure if that's related to COVID or not. It may be in some regard, because one of the risk factors we know for IH is weight gain over a rapid period of time. And I know that that's probably something that you guys have already addressed. But during the pandemic, there have been some folks who've gained some weight during that time as well, and led a little bit more sedentary lifestyle. And so I think that maybe that's part of why we're seeing that. We really don't know. But we do treat IH. It is different than migraine, and it's different than the migraine treatment by far, and a different workup in general. But the biggest thing you can do for IH is weight loss, diet, exercise. Those are going to be your best bets to work through.
Wow, that's really interesting. And I'm going to totally butcher Jackie's question because it has a medical word and terminology. And Dr. Hawkinson and everybody watching knows that that's not my strong suit. Jackie says, does this work with trigeminal neuralgia?
Trigeminal neuralgia, great question. You did great, by the way. That was good. So the CGRP meds were not studied in trigeminal neuralgia particularly, so it is difficult. A lot of our trigeminal neuralgia patients, though, do have some crossover with migraine, and we have tried it in some of those patients, along with Botox, actually. And so we get mixed reviews, to be totally upfront with you. Again, I don't have data to present for that because it hasn't been studied that way. Trigeminal neuralgia is a very different headache type altogether, very difficult to treat, very, very painful. I think if anyone's been to the dentist and had that zinger when they weren't quite numb yet, that's similar to what they're feeling all the time in different distributions, and it's very difficult to treat. There are some medications, but a lot of people end up going for surgical routes, and our neurosurgeons here do a beautiful job with our trigeminal neuralgia patients as well.
And why is it called trigeminal neuralgia?
Absolutely. So trigeminal neuralgia is actually pain in the trigeminal nerve. So it's actually a nerve that branches out into our face. So we've got a top branch, a medial branch, and then our lower branch. And so you can actually have any 1, 2, or 3 of those areas is affected by trigeminal neuralgia, and it's just a really intense shooting pain. It's different than what migraineurs feel with that pulsating and throbbing pain. This is a really sharp, terribly electrical type pain that shoots through the face, and we believe it comes from the trigeminal nerve and then possibly the nucleus of that nerve back in the brainstem and where everything travels by. And so the reason our surgeons get involved is, again, getting into a little bit more technical, but there are blood vessels that can travel very close to that nerve and can inflame it and cause problems. And so our surgeons can get involved to try to reduce that contact and help with that pain.
Wow, that just sounds awful. Okay, so Isaac is our reader, and we really appreciate him. And he read where eating ice cream can help with migraines, and it's coming up with summer. I got to say, though, when I eat something too cold, I get a headache.
I hate the brain freeze.
Yeah, it's not a long one, and it's not a migraine, so I'm not making light, but...
I have not read that study, obviously, or article that he's read. I'm all for it. If it works, go for it. I will say, again, too hot or too cold food, as we just noted, it can actually cause a headache. And for our trigeminal neuralgia folks, that's a huge trigger, actually. So we actually recommend not to do anything more than lukewarm temperatures for them. But, if it works for you, I guess go for it.
Yeah, and you know what? And Isaac almost stumped our docs yesterday because he can find these most obscure studies. So if this is a study, Isaac, send us a link again because we want to look at that more. Cindy said, I had a friend who had migraines for years, and then she told me they stopped as soon as she stopped taking birth control. Is that a common side effect of birth control?
So that's another tough question that has multiple edges to it. So birth control and hormones in general in females are a huge trigger for migraines. And sometimes birth control actually makes the migraines better, and sometimes it makes them worse. And it's very hard to predict which patients are going to go which direction. The really big key here, and something that I really want everyone to make sure they're talking to their physicians about this, is if you have migraines, you need a very careful clinical history being taken to see if you have aura. If you do have an aura with your migraine, we actually recommend not to be on estrogen-containing oral contraceptives due to the increased stroke risk. That data is based on a long time ago study with our higher dose estrogen-containing birth controls, but currently we still typically recommend not to do those. And so we do ask you to talk with your primary care physician, your gynecologist, your neurologist about your risk. And then it's really a risk-benefit ratio that you discuss. But in terms of birth control in general, it's variable if it's a trigger for different folks. And interestingly, one birth control can be a trigger for the same patient, and then they take a different one and it is not. So it's actually similar to a lot of different medicines. People just tolerate things very differently.
Okay, we're going to do one more migraine question, then ask some COVID questions, and then we do have more migraine questions if time permits. Carmen wants to know, what are the side effects of the new meds that you spoke about?
Absolutely. So that's where another really great part of these medications is. So for the injectables, the biggest risks, so I kind of break them down into categories. So it's like some of these things fit in, your old Sesame Street words. But basically, we have two of the injectables that have a pretty similar safety profile, and one kind of sits outside of that a little bit. But the most common things are going to be injection site reactions. So I usually warn people up to the size of a fist. Honestly, a pretty big red bump or lump. It's a pretty big one. It can be itchy. It usually goes away in a couple of days. If it gets larger, obviously, again, speak with your physician. There is a risk for pain. One of them is a little more painful than the other. I just talked to the company not long ago, and they're going to change their citrate base. So it has kind of an acidic base in it right now, and they're going to try to get that out of there so it won't be as painful. But there's a little discomfort. Lasts 10 to 30 seconds, so it's not a long time. There's a risk of a rash with all of the medication, all three of the injectable medications, so it's something to be aware of. And with one of them, and that's the one that we really need to focus on with our patients when we make those decisions, constipation is a very strong risk with that one. There have been some bowel obstructions reported, so it's something we really take seriously and discuss. And then also high blood pressure, and to the point where it could go up high enough to be hospitalized. That is incredibly rare, but it's something that we talk through, and we talk through the risk benefits, and we have a very distinct plan in place for that. So again, if you talk to your doctor, they're going to be able to go over all of that. And then in terms of the oral medications, anywhere from, depending on your dosing, 2 to 4% of patients had nausea with the medication and some somnolence. They felt tired. But the majority of the patients actually had no side effects with those medications at all, so they've actually been pretty safe.
Yeah, and I think it's, prefer a baby's fist to like Shaquille O'Neal's fist.
Absolutely.
But, it's interesting you talk about that. People are still wanting these drugs because of the benefit they offer.
Absolutely.
We know the good safety profile for these COVID-19 vaccines, and people are still hesitant to get it despite, what not only these drugs that you're talking about, but other drugs that we see advertised on TV every day
Absolutely.
that have a litany of adverse events with
Absolutely.
them. So.
Absolutely.
Yeah.
And I think that, and I always, again, back to just to tie it in with headaches, I would say to all my migraineurs and anyone out there with any headache type, having COVID-19 headaches are much worse still than having a few days after the vaccination. And that's if you even get it with a vaccination. The folks that we are seeing in our long COVID clinics, it's been really tough on them with these headaches that are lasting weeks to months that don't break no matter what we do. So I highly recommend the maybe no headache to maybe 5 days of headache over the weeks to months long headaches that these folks are dealing with.
All right, Dr. Hawkinson, Dean wants to know, how long should a vaccinated person isolate from unvaccinated children after returning from traveling and potentially been exposed?
Yeah, right now I believe the guidance that if you are exposed and you're fully vaccinated, you don't have to quarantine, particularly for doing things. I think this then, based on that, this will go to your own preference of what you would like to do, if you would prefer to sit and wait out some time. But really the guidance is if you are exposed, the really only thing you have to do if you are fully vaccinated is monitor for symptoms, whether that's fevers, chills, cough, things like that. If you feel more comfortable because you've been exposed and you want to quarantine yourself away from other unvaccinated people, you can do that. There's no good guidance on how long that would be. We continue to have really good evidence, and this is based on probably not so much of the circulating or prevalent variants such as the Alpha or the Delta right now, but we have very good evidence that your ability to transmit the disease is probably reduced by 90% if you're fully vaccinated. So there is no specific concrete guidance on what to do. Just understand what the basic guidance is, and that if you are fully vaccinated, you don't have to quarantine or isolate. Just monitor for your symptoms. However, if you do feel more comfortable doing that, if you do want to do it for several days or a week, that is certainly up to you.
Susan has kind of a related question. She's vaccinated. She wants to go visit family out of town. She wants to know, is it safe to go to dinner? Is it okay to stay all night? She's feeling unsure about staying all night. She doesn't know what to tell family. Her question ends up being, so why even bother to get vaccinated if it doesn't protect you from the unvaccinated? She wants to know, what do I say to them if you say, Dr. Hawkinson, you should not stay with them overnight?
Well, it does protect you. The vaccines do protect you. We know that your whole spectrum of disease, whether that's asymptomatic disease or mildly symptomatic, but especially moderate, severe, and critical disease, you are protected from all of that from if you do get exposed and infected. So you are able to go do that. But understand that if they do have it, you may get it. Overall, you are going to be extremely protected from having to seek medical attention, going to the hospital. But what is your level of comfort with doing that? If you still feel more comfortable with distancing and masking or doing things outside rather than indoors, then certainly do that until you have comfort of getting away from some of those non-pharmaceutical interventions. But overall, yes, right now the guidance is, and the evidence would show that you are protected from those unvaccinated people. That is the benefit of the vaccines. You are also right now protected from the variants as far as we can tell. Although your antibody neutralization may be less with some of the variants, you still have very good T-cell immunity with these vaccines that the vaccines provide, so you are protected. But just understanding that and then understanding further what you feel more comfortable with, hopefully you will come to a decision of what you can do. But that is why we do have the vaccines, so we can visit with friends and loved ones and do those things that we haven't been able to do for the last year and a half.
Okay, and then Susan, I don't know if it's the same Susan or a different one, but they talk about, they read in the New York Times that there's just, appears to be a growing list of long COVID symptoms growing, and it's among asymptomatic as well as people who had mild cases. She's hoping that we'll do a show on that at some point, and we certainly can, but what are some of the more common And have you heard of any bizarre that are being added to the list?
I'll start and then throw it to you. Certainly, and I had the CDC updated a little bit of guidance on managing long COVID. Within the last couple days, they just kind of updated their website. I've been in contact with Dr. Brandon Comfort and Dr. Leslie Spikes, who head up our multidisciplinary long COVID clinic here at the health system, and actually had to refer a friend recently to ENT because even though he had COVID in October, he still couldn't have smell right now. So, those are common. We do know that they are very prevalent, up to 30 or 40% of people, depending on what studies you look at. Those symptoms mostly right now, the latest data, majority of people will have fatigue, brain fog, shortness of breath or cough, and loss of smell still. Those are the most common. And I know here at the health system, we do have up to 30% of our patients needing to see 2 or more specialists to identify that. But even going away from the long COVID symptoms, there's a study out of the VA that was recently published that also showed that people who have COVID-19 also are at higher risk of developing other medical problems that they didn't have, such as high blood pressure and diabetes and chronic migraines and headaches. So those things affect you as well, and that is why it is all the more important, especially if you're young and healthy, to go get vaccinated to help prevent some of those symptoms. So I don't know what you are seeing or if you're seeing any of those in your clinics.
Yeah, so beside the headache, which we've talked about a lot, the brain fog. The brain fog's been a pretty big thing. The other thing that we see a lot of is just what we call paresthesias, which is kind of tingling in different parts of the body. So that's been something that a lot of people have reported. And so for the brain fog, I like to focus on that because I think it's the hardest one out of all of them, that with the fatigue. We're not finding at this point, and I always say that early, a really great cause for exactly what is causing that mechanism. And it's not in just the folks who had really severe infections with the really bad encephalopathies or infected problems in the hospital. This is also with the people in the community who got milder cases. And so unfortunately, we can do scans and those have not been very revealing. And so most of the time what we're doing is recommending to be, taking your vitamin B12, and that's something that sometimes can help with that. We'll check thyroid to make sure that that's stable. And then ultimately it goes back to all the things that are the hardest parts to do that don't get fixed with a pill, which is the diet and exercise and getting the good sleep and allowing yourself some grace and time to heal. I'm a big proponent of if you need a small nap in the afternoon, if it's not going to affect your sleep that night, then that's something that you may have to do for a short period of time to keep yourself clear and able to function the rest of the day. But really it is a slow recovery for a lot of those folks, but there is hope because most of them are getting better. It's just taking time for that to go away.
Yeah, and I think, it's interesting you talked about we still don't know what it is. We don't. We are taking steps daily to further elucidate the etiology of some of these problems. A recent small study looked at long COVID people versus people who had COVID who don't have those long COVID symptoms. They found, again, some overproduction or release of some of those cytokines or chemokines or some of those cellular molecules still in those long COVID patients. So we are getting closer, but we don't have one full answer or panacea answer at this point.
And I think that's what makes it so difficult for people to understand. We don't have a pill that's going to make it better because we don't have the exact underlying what are we going to do about it. And so again, I always tell folks the harder parts are making the lifestyle changes. A pill is an easy thing to do every day, but it's really making those lifestyle changes to try to help yourself in the long run.
And investigations are still ongoing too, to look at if I have long COVID and I get the vaccine, is it going to make me better? Because we know that anecdotally, and I think in one small study, up to a third of patients did have an improvement in their symptoms with the vaccine as well. So.
Okay, and Ashley wants to know if we have any detail on the detection of COVID in vaccinated individuals. She's wanting to know, is their viral load different? Is it smaller, less?
We don't hear at the health system per se, but there are small articles out there that show that, the viral loads at any one point in time are up to 2 log or 100 times less than people who are unvaccinated. So with that, the clearance seems to be sooner as well. So overall, vaccinated people seem to have less replication of the virus and have it going on for less amount of time. We all think that contributes to the ability to transmit it less as well.
Okay, a couple of questions, and then we're probably got to call it an update, and we
All
will
right.
follow up on questions tomorrow that we don't get to. Landon wants to know, and sometimes I'm reading, I don't listen. Did you mention, Dr. Ford, you said caffeine can be a trigger. What about alcohol? Is that good or bad for headaches and migraines?
Typically, alcohol is a pretty big trigger, unfortunately. And I have some patients that's literally...
It is the next morning.
I know. It definitely is the next morning. Unfortunately, I have some patients that literally one glass of wine, and by the end of the glass, they're already getting a headache. Unfortunately, it's one of the biggest triggers we hear about. And avoidance, unfortunately, is the only way for that to really be eliminated. So it's a very big trigger for a lot of our patients.
Okay, and the last question is going to go to me.
All right.
I live with someone who has migraines, and I want you to settle it's not a marital dispute, it's just I'm skeptic. So you tell me if I'm right or wrong.
All right.
We'll go to bed, and my husband will say, I'm going to wake up with a migraine. And I'm like, how do you know that? And he goes, because I have a headache. If you go to bed with a headache, you wake up with a headache. Is that true?
Oh, now I'm going to get in the middle of this.
Yeah, the wife always
Like, wait a
wins.
minute.
I'm going to tell him, the doctor said.
No matter what the answer
But
is, the
only
wife always
only
wins.
if I'm right.
You know, I'll be honest, that one's a tough one because everybody's different. So a lot of people with migraines actually know they're going to wake up with a migraine. They have this sense that comes onto them even up to a couple days before. Increased urination, increased yawning, just an odd sensation, different cravings that can occur. And that's even 2 to 3 days before they actually get the migraine. And so he may know that. He may have a sense that, hey, this is going to be a problem. Going to bed with a headache and waking up with a headache, if you don't treat that headache appropriately or that migraine appropriately, yeah, you probably will wake up with it again.
Now I
a lot
have
of
to
the
tell him
time-
I'm sorry.
Yeah.
Yeah, he probably knows. He probably
Yeah.
knows. So most migraineurs, they just know. They just absolutely know.
I know it's awful. I do know it's awful.
It is.
All right. Thank you, Deetra.
Absolutely.
Well, tomorrow we celebrate Juneteenth early. We have special guests, and those include Chaplain Clarence Miller, who will share his personal reflections and remembrances of this special day. We will also hear from Broderick Crawford. I love Broderick. He's been around a long time.
Yeah, he's a great guy.
Work with my boss, Dr. Hinthorn. He is the president of the New Bethel Church, or NBC, Community Development Corporation, on what's happening around town to celebrate Juneteenth. Plus, Amanda Cackler is back to help answer questions and update the vaccination rate among our inpatients. Join us tomorrow. This should be a great update. Final thoughts?
I just say go out there and get vaccinated.
Yeah.
Vaccinate your children, vaccinate yourself, and encourage your friends to do the same.
Yeah, I have to echo that. We are learning more and more about this virus and its evolution, this continued evolution, always staying one step ahead. Certainly, the Lancet paper showed that the Alpha or the UK variant didn't cause more severe disease. Those questions are continually being investigated, especially with the new Delta variant. Again, we know that it is out there. We know that if you are unvaccinated, you are a susceptible host. We have seen young people come in day after day with infections. We don't know that it is the India variant, the Delta, or the Alpha variant, but we know that those are out there and prevalent in the community. So the way to protect yourself against acute disease, against COVID-19, the long COVID, is to get vaccinated. Protect yourself, protect your loved ones in your community. Please go out and get vaccinated. So, as we say goodbye, remember we have plenty of vaccine available, and you can schedule your shot by calling 913-588-1227 or go to the kansashealthsystem.com/vaccine or use your MyChart. We have plenty of supply available. Please come get the vaccine. And please make sure that your decisions around COVID-19 and vaccines are based upon reputable information, not TikTok or the made-up news network, MUN, as Dr. Stites would like to say. So please, and if you have questions, please submit them. We will be happy to answer them. See you tomorrow.
When you're part of the made-up news network, what you are really listening to is the ruries, the rumor reporters. Rumor reporters don't report facts, they report rumors. And the problem with rumors is they aren't scientific information. It's not stuff that's based in science.
Whoa, whoa.
I think it's all about where you want to get your information. Are you getting it from Facebook posts and TikTok, or are you getting it from the FDA, the CDC, other physicians who know what they're talking about? I know that certainly if I got diagnosed with cancer cancer, I'm not going to go to TikTok and look to see what somebody says about what do I do now and what do I get for chemotherapy. So I think you have to understand where is your source of information.
At some level in life, you have to distinguish between that which is made up and that which is rumor reporters. Don't listen to the rumor reporters because they're not going to guide you based on science. They're going to guide you based on fear. But what we've tried to do in this program, and we continue to do, is to talk about the intersection of faith, hope, and science. But at the heart of each of those expressions is honesty and integrity, because we think ultimately that keeps you safe.